Today in Contextual Point, I'm going to talk about the diagnosing of brain death for step 2 purposes. I think this subject is a little bit underlooked in some question banks, but also it is so important for step 2 exam. So let's get started. Before talking about brain death diagnosis, we have to know the things that can mimic brain death. This list is not conclusive, but it gives fundamental understanding what could be mimic brain death. Electrolyte imbalances, endocrine problems, or even neurologic problems like locked-in syndrome could mimic brain death. Also, the most important thing in here is abnormal core temperature. We cannot diagnose brain death in hypothermia. This is so important in step 2 purposes. Please don't forget that. Also, abnormal blood pressure is important. And intoxications like opioids, benzodiazepines, etc. could also mimic brain death. We have to eliminate all things that can mimic brain death to investigate brain death. So what we need to diagnose, there are three things that we need to diagnose brain death. First thing is persistent coma. Second thing is brainstem areflexia. That means we should see no signs of brainstem reflexes, like corneal reflex CN5 and CN7, and gag reflex CN9, papillary reflex CN2 and CN3, vestibulo-ocular reflex CN3, CN4, CN6. This is important. The CN3, CN4, and CN6 are the cranial nerves that we need to move our eyes. So the nerves are innervating the muscles of eyes. Please look to Google for that. Also, cough reflex, oculocephalic reflex, and also obviously spontaneous respiratory drive. So we cannot diagnose brain death in a person who has spontaneous respiratory drive. We'll talk about that a little bit later. And important thing in here is we could see deep tunnel reflexes in a person who is in brain death, because DTRs are not related to brain. It has circuits from coming from the medulla spinalis. So even in brain death, we could see DTRs. So there could be some questions, not only in the context of medicine, but also in the context of ethical questions that you can see. Families could ask you, our patient has some reflexes and some twitching movements, so why you are calling our patient's brain death? So aware of that. You can also expect a question like that in an ethical manner. So the third thing is apnea test. This is important. So apnea test is assessed to patient whether has respiratory drive or not. So, but we need hemodynamic stability to do apnea test. Basically, we are pre-oxygenating the person with 100% oxygen, and then seize respiratory support and observe for respiratory function. If there is no breathing for more than 10 minutes without respiratory support, we say the apnea test is positive. And if one of the findings are inconclusive, we need to do ancillary brain tests. And ancillary brain tests are basically to assess cerebral blood flow or electrical activity. This is important. We can use EEG, radionuclide brain imaging, cerebral angiography, cerebral scintigraphy, transcranial Doppler. So these all make sense because we are just trying to assess cerebral blood flow or electrical activity of the brain. How many physicians are needed for diagnosing brain death is differs from state to state. So some states give permission only one physician, or some other states needs two physicians to diagnosing brain death, or in some states any physician could diagnose brain death, or in some states only permits neurologists or intensive care specialists to diagnosing brain death. So probably you will not uh, see any question in step 2 about how many physicians do we need to diagnose brain death, or um, or do we need neurologists, uh, because it differs state to state. And we don't need to get consent if we diagnose brain death. So we can cease cardiopulmonary support if we diagnose brain death. But this does not mean that we don't need to talk with patient's family. So there are no real situations as we diagnose brain death and immediately cease the support from the person. Even we have right to do this does not make sense, because we should talk with patient's family, uh, tell them what is brain death and what happened to the person, etc. So this is really important in the concept of ethical things in step 2. So please give attention to this topic, and I give an advice to you: please study brain death ethical scenarios in other sources. This one slide could not be able to give you all aspects of ethical scenarios of brain death. And also, if decision maker disagrees with brain death diagnosis, we may consult this case the hospital ethics committee. So this is not step 1. You know, we always, people always says, please do not choose the choose hospital ethics committee as an answer in step 1, because it will always wrong answer. It does not works as like in step 2. The correct answer could be hospital ethical committee in step 2, even rare. So even we don't need to get consent, we still may need to consult the case to the hospital ethics committee. So ethical things in brain death are a little bit complicated, and also really, really important, and always having questions in step 2. So I'm guaranteeing you that you will probably see some brain death questions, and this video fundamentally gives every aspect of brain death diagnosis, and probably a lot of questions that you can answer via this video. So yeah, if you like this video, please subscribe my channel and have a great day.